You're in your 40s, maybe your 50s, you still train, you still want to move well, but something changed. That shoulder won't come down. The Achilles flares every time you push. The knee that used to bounce back in a week now takes 3 months. Then someone at the gym says 4 words that send you down a rabbit hole. You should try TB-500. A few minutes of surging and you're buried. Miracle healing claims, Reddit dosing charts, the Wolverine stack, and underneath all of it, quiet warnings about cancer. I'm Dr. Zaid Fadul, board-certified family physician, Air Force flight surgeon, and founder of the Spill Concierge. Over the next 10 minutes, I'm going to tell you what we actually know about TB-500, what we don't, and if you decide to move forward, exactly how to do it in Teledilla. Because the biggest mistake people make with TB-500 isn't the dose, it's that nobody's watching. Okay, let's dive in. Search TB-500 and you'll see it called Thymosin beta-4. Those aren't the same thing, and that distinction shapes everything else in this video. Thymosin beta-4 is a protein your body makes, 43 amino acids found in nearly every cell and body fluid you have. TB-500 is a fragment of it, just 7 amino acids. Think of thymosin beta-4 as a full toolbox. It fights inflammation, keeps cells from dying, and drives tissue repair and new blood vessel growth. TB-500 carries mainly that last function. Why this matters practically, almost every impressive study you'll see quoted on a product page was run on thymosin beta-4, not the TB-500 fragment. So keep that filter on for the rest of this video. So what does that one piece actually do? Picture your repair system as a construction crew after a storm. Damaged tissue needs cells to arrive, clear debris, and rebuild. But in tendons and ligaments, the roads barely exist. That's why tendon injuries drag on for months. TB-500 acts on a protein called actins, which governs how cells move. Better cell movement, in theory, means the crew arrives faster. The animal data is genuinely interesting. In rat wound models, full-length thymosin beta-4 increased skin regrowth by 42% at day 4 and 61% at day 7. In a mouse bone healing study, it improved peak force to failure by 41%. Those are animal studies, not human trials. So does any of that translate to a human? For tendon repair, muscle recovery, joint pain, or athletic performance, TB-500 has no completed human clinic trials. Not mixed results, none. What we do have is early human data on the parent protein thymosin beta-4 in other applications. Thymosin beta-4 eye drops produced a 35% reduction in eye discomfort in a phase 2 study of 9 days. A skin ulcer trial in 73 patients showed about 25% complete wound closure at 3 months. A heart attack trial in 96 patients showed benefit in early treatment subgroup. Real signals, different molecule, different tissue, different route than what you're considering. One more thing worth noting, researchers specifically flagged the placebo effect as a major driver of how well peptides seem to work. When you spend $300, inject twice a week, and actually rest the injury, you will feel better. Some of that is real, some of that is the rest. We can't cleanly separate them yet. That's not a reason to dismiss your own experience, it's a reason to measure things instead of guessing. We'll come back to that. This is the part that deserves your full attention, and it's the most distorted topic online. Short-term safety looks reasonable. In phase 1 human trials, thymosin beta-4 showed no dose-limiting toxicities and no serious drug-related adverse event. Reported issues were mild, injection site reactions and headaches. Those trials ran 10 to 14 days in healthy volunteers with pharmaceutical-grade products. Now the concern. Thymosin beta-4 is overexpressed inside multiple human cancers: colorectal, breast, liver, thyroid, lung, melanoma, and gastric. That overexpression has been linked to a 4.4-fold increase in tumor blood vessel formation. In melanoma models, high-expressing cells produce 46.7 metastatic lung nodules versus 10.9 in control. Here's the honest read. No human trial has shown that TB-500 causes cancer. That's an important sentence. The concern isn't proof, it's mechanism. This molecule builds blood supply and helps cells migrate. Those are exactly the 2 things a tumor needs. If you have something small you don't know about yet, you don't want to be feeding it. That's not a reason to panic, it's a reason to screen. And screening is something you can act and control. Now that's the risk everyone talked about. Here's what almost nobody does. I need to draw a hard line here because this is where nearly every conversation about peptides goes sideways. There are 2 completely separate issues and they get blended together constantly by critics and by sellers. Issue 1 is the science. Does this molecule do what people claim? For TB-500, the honest answer, promising animal data on that parent protein and no completed human trials for the injuries you care about. That's a knowledge gap. Knowledge gap's closed. Research needs to get done. Issue 2 is the product itself. And this is where my biggest concern lives. Even if TB-500 works exactly as advertised, even if the science lands perfectly 5 years from now, that tells you nothing about the vial on your kitchen counters today. Gray market peptides carry documented risks of contamination, mislabeling, and inconsistent potency. So think about what you're actually doing. You're calculating a dose down to the 10th of a milligram from a vial where the true contents were never independently verified. It's not precision, it's a house of cards. And this is the part that frustrates me most about the online conversation. Hundreds of pages debating loading phases and injection sites to stack ratio, extraordinary attention to variables you can't control, and almost none to the one variable that determines everything. I'm not worried about the peptide. Peptides are just molecules, and some of them will turn out to be incredibly useful like GLP-1s. I'm worried about an unregulated supply chain, marketing dressed up as science, and people making careful decisions using unreliable information. Fix the sourcing problem and the verification problem, and this becomes a much more reasonable conversation. So who shouldn't be in this conversation at all? There's no official contradiction list because this isn't an FDA-approved drug. But based on the biology, these are the hard stops in my practice. Active cancer or any personal history of cancer. Pregnancy or breastfeeding, since there's no reproductive safety data at all. Active proliferative retinopathy, where new blood vessel growth in the eye is the problem, not the solution. Autoimmune conditions, where immune effects are unpredictable. And competitive athletes, since TB-500 is a WADA prohibited growth factor and labs can detect it. If you're over 45 and behind on cancer screening, you're not automatically out. You're just not ready yet. Get current first. Everyone else, let's talk about how to actually do this. The protocol circulating online looks like this. A loading phase around 2 to 2.5 milligrams twice weekly for 4 to 6 weeks. Then 2.5 milligrams once weekly for maintenance. Reconstitute with bacteriostatic water, refrigerate, use within about 30 days. That's what's out there, and I'd rather you hear it from me with context than find it on a vendor page without any. Here's the actual context. Those numbers come from user reports and vendor recommendations, not from clinical trial. The human safety studies people cite used IV, full-length thymosin beta-4 at hospital-controlled dosage, ranging from 42 to 1260 milligrams. Different molecule, different route. You can't convert one into the other. And remember what we just covered. You can dose this perfectly and still be wrong because the precision only matters if the vial is what it says it is. So the practical takeaway isn't never use it. It's this: understand you're using a borrowed protocol, not a validated. That changes how carefully you monitor it, not whether you can proceed. Now, what happens when people run 2 of these at once? If you've researched this at all, you've hit the term Wolverine stack. TB-500 alongside BP-157, named after the X-Man who heals in minutes. The pitch is well built. BPC-157 works locally, supporting collagen and blood flow right at the injury site. TB-500 works systemically, signaling repair throughout the body. Local precision plus whole body reach. It's a compelling theory, but no published study, animal or human, has evaluated these two together, or any peptide combination. My patients who swear by this stack can describe real recovery. I don't dismiss that. What I'd ask you to hold on to is one specific point. Both compounds promote angiogenesis. Putting them together may amplify the exact mechanism that can promote cancer growth we discussed earlier. That doesn't make the stack off limits, it makes screening and monitoring non-negotiable. Which brings us to the part almost nobody does. This is the difference between a physician-guided protocol and a vial from the internet. Ask most people running peptides what labs they've drawn. The answer is usually none. No baseline, no follow-up. They're managing themselves based on how they feel, which is risky. There's no validated monitoring protocol for TB-500, but no validated protocol doesn't mean monitor nothing. We apply standard drug safety principles. Here's what I run for my patients on TB-500. CVC with differential at baseline, then every 3 months. A comprehensive metabolic panel at baseline, then every 3 months, tracking liver and kidney function. IGF-1, fasting glucose, and hemoglobin A1C to watch for blood sugar dysregulation, especially with stacking. Age-appropriate cancer screening, think colonoscopy, mammogram, PSA, and the Gallery multi-cancer blood test. And an injection site assessment at every visit for infections and sterile abscess. That screening line isn't fox checking. With a compound that builds blood supply, staying current on screening is the best risk reduction available to you. And notice what's on that lid. None of it is exotic. It's disciplined primary care medicine, which requires a physician who knows your history and has time to actually read your results. That's the real gap. Access to peptides take 10 minutes online. Oversight is what's missing. Whatever you decide about peptides, the following principles carry much stronger human evidence and should be running underneath any protocol. Progressive loading and physical therapy. Still the most evidence-backed treatment for tendinopathy. platelet-rich plasma for recovery and sleep, protein intake, vitamin D, and nutrition. Peptide works best on top of a foundation, not instead of one. So here's your bottom line. TB-500 is a promising molecule with real biology behind it and a thin human evidence base. Supervision is critical for great long-term results. When people ask if I'm anti-peptide, the answer is no. I'm anti-guessing. Guessing on the source, the purity, the dose, and whether anything is actually happening inside your body. If you're screened, you know you're using a bar protocol and you're monitoring properly, you're making an informed decision. If you're guessing on all three, you're not. That's the whole difference, and it makes the entire reason Bespoke Concierge MD exists. If you want a physician to have a real conversation about emerging therapies, without rushing you, dismissing you, or handing you cookie-cutter medicine, that's what we're built for. Membership is limited because we work personally with every patient. Links in the description. If this helped you understand TB-500 more clearly, hit like and drop your question below. I read them all. If you want to go deeper on the Wolverine stack, the video on the right breaks down BPC-157. The playlist on the left covers peptides and related health issues in detail. And hit subscribe. I publish evidence-based medical content every week that could change your life. See you in the next video.